All right, can you see my screen now?
Yes.
Okay, great.
Yes.
So I'll kind of pick up as best I can where Jerry left off. I agree with the comments he was saying, everything being said. I came in at UNC, we have a pretty large coronavirus group that dates back 3 decades, starting with mouse hepatitis virus, and then moving to SARS and MERS. Most of the work I've done with them is more MERS than SARS because of the timing of it, that SARS kind of went away and MERS kept popping back up. So we were doing therapeutic studies in MERS, assuming that that was an ongoing problem. In January of this year, we had 20 SARS mice alive, so those got quickly bred up again. Stan Perlman, who designed the other mouse that we were talking about today for SARS, with the ACE2 receptor at Iowa, he had 0 mice. And so he is on the list trying to get mice sent back to him as well, just like everybody else. But I wanted to first highlight this website. They put up a new page here on the MGI site for mouse models of coronavirus infection that kind of lists the SARS mice and the MERS mice. It's a nice resource if you're trying to look at how they were designed. Very useful. I don't have any I don't have any SARS. I'm at home and I don't have any SARS slides here at home with me. I do have a MERS slide I can show you. I think my SARS experience very much mirrors what Jerry already showed. I think the big difference between MERS and SARS in mice, from what I've seen, is that SARS tends to hit the bronchi and bronchioles more than MERS. The MERS disease is more truly interstitial in the mouse model. I'll show you a couple pictures and then I have a live slide I can show you. So this is the remdesivir publication that is actually, if we've got just 1 minute for a fun aside story, so I was called, historically the coronavirus group didn't use a veterinary pathologist. I came in and really started working more intensively with them about a year ago. And interestingly, they had submitted a paper on using remdesivir as a therapeutic, either post-exposure or prophylactically in mice. This is in collaboration with Gilead, who you've heard in the news. And last summer, they had submitted this without pathology, without a veterinary pathologist. And they got pretty harsh reviews back and said, you really need to find a pathologist, at which point I'd kind of been working with them already. We really worked up the pathology on this model. I was really excited. I thought we were going to resubmit it and they were going to regret asking for the help of a veterinary pathologist because we added all these beautiful figures. Much to my surprise, I was responsible for getting it rejected because they did not believe my pathology. And I firmly believe it's because it's an interstitial phenotype, and it was very hard for a reviewer who didn't have a pathology background to appreciate hypercellularity and not giant cuffs of lymphocytes around an airway. So that's why this figure now has all these annotations in it, and a mock that shows very thin alveolar septa right next to hypercellular ones. And so in this figure, you can see kind of the phenotype of the MERS infection, where there's hypercellularity with mononuclear cells. And then there is some protein in the air spaces and mild kind of early hyaline membrane formation. I don't think mice do a great job of making the really robust hyaline membranes like you see in humans. One thing that the authors had, or I'm sorry, that the reviewers had asked for after, so a fun part of the story, I guess, is that I was responsible as a pathologist for getting this paper rejected. We wrote a letter to the editor begging them that if they had a pathologist review my pathology comments, I promised that they would agree that any of the 4 panels to the right did not match the panel to the left and in fact were diseased, because what the reviewer had said was that there was no pathology to be seen, that these look like normal lungs, which is not right. So they had asked us to go back and somehow quantitate this based on something that had already been established. And so in the literature, there's not a great scoring scheme for this phenotype in mice. We pulled on two things. One, the American Thoracic Society has a lung injury score shown up there to the left that I have pulled up here. It has these 5 features, and it's not great, honestly, for SARS and MERS, but it's something. And I don't think it captures the lesions perfectly, but it does capture some element that does quantify the severity, and it made the reviewers happy. For instance, I do not, so between the SARS and the MERS mouse that I work with, the MERS mouse just has more neutrophils in circulation, and and one of the criteria for grading has to do with how many neutrophils are in the interstitial space. And so that metric is kind of useless, to be completely honest. The other thing is the whole infection itself isn't very neutrophilic. It's much more lymphocytes and macrophages. So this isn't a great scoring scheme for its particular features. But like I said, that said, it is a metric that does seem to capture the severity. And so it ends up that the ATS, the American Thoracic Society, is reevaluating this paper. It's a consensus paper that came out a couple of years ago. They're currently doing that right now, and we wrote them before all of this happened, actually, and said, please consider infectious models more heavily next time around, because this tends to be more toxicity in acute lung injury. The other thing we did was we also utilized from the University of Iowa. This is the group that's out there, including David Meyerholtz, who's a diplomat. He has a scoring scheme for DAD in mice in this paper. This is a respiratory syncytial virus paper, and this similarly mirrored the ATS scoring that we did. It's shown here. It's just a very simple 1, 2, 3, 4 scoring scheme that we applied. So it worked. And this is what we were doing with this manuscript was we were actually trying to get Gilead to start clinical trials in Saudi Arabia with this, presuming that there would be another outbreak. That was supposed to start happening this spring. Obviously, clinical trials are going on in the US now with it. And so far, so good. I think in the beginning we mentioned the endosomes, and that is the theory behind the hydroxychloroquine that you hear as a treatment, that the hydroxychloroquine alters the acidity of the endosomes. And that was kind of the thought behind why it might work or not.
What's the 2-sentence version of how remdesivir works?
It's an antiviral for RNA viruses. It introduces mutations to the replication cycle, so you're getting transcripts that are stopped short, so the virus can't replicate. Somebody had asked about the, so moving away from MERS and going back to SARS-1, I guess we might call it now, and SARS-2. This is an antibody that we use. It's a wonderful antibody for SARS, and it works on SARS-2 as well. It's pretty dummy-proof, to be completely honest. It's an excellent reagent. And it cross-reacts. It's the nucleocapsid, and it's a rabbit polyclonal. And as far as I've heard, despite it being commercially available, there has not been, like, they have plenty of it. So, let's see, I think Jerry covered basic SARS pathology pretty well. I actually have some SARS-2 pathology, but to be completely honest, I don't want to share that if we're recording this. What I'll say, I won't share the slides that I have. What I'll speak to, I guess, is is kind of the process that we've gone through so far. So much like for SARS, it uses the same receptors, so those mice work. We have a mouse-adapted version of the virus now that causes disease. There's replication in the nasal cavity as well as in the lung. We've looked at a couple tissues for outright pathology. That's just starting literally this week. And I haven't seen anything. We looked at heart, lung, liver, nose, and kidney. Heart because of what was being reported with the hydroxychloroquine, and I didn't see any overt replication in the heart or anything like that. The kidneys we haven't evaluated yet, and same with the liver. But we are getting nice replication of the mouse-adapted version of the virus in the nasal cavity and the lung. The mouse-adapted version of the virus is just an engineered 2 amino acid substitution in the receptor binding site. And the other thing to remember about coronaviruses is that the genome is a swarm. So any kind of clone that you have of it is still a swarm genome. Like I said, I don't feel comfortable showing you those slides since we're recording, but I do have a couple human COVID cases. If I can switch over to my microscope, I'll show that.
If you want, and we'll break at the end, I can stop the recording, and if you want to share those, but I would still remind everybody that that's not to be discussed outside of this group. But I leave that up to you either way.
So I would, so at UNC, we have decided not to do autopsies on patients that die of COVID to be sensitive to not exposing extra people and not using extra PPE. So these cases actually we have gotten sent to us from other institutions. And we get spoiled in veterinary medicine, especially in what we do in comparative pathology, that we get very fresh cases. The patient I'm showing today was a 40-year-old male found dead. So no treatment in a hospital, but was COVID positive or SARS-2 positive. Because of the, I guess, I'm sorry, in human medicine it's called found deceased, not found dead like we call it. Because of that though, there is not any epithelium lining bronchi or bronchioles in this patient. What you can appreciate is very similar to what I've seen in MERS, an interstitial pneumonia, pretty severe congestion. I know we don't know what side was down in this patient, but pretty much all sections have severe congestion, edema, early hyaline membrane formation, and then lymphocytes, macrophages, alveolar max, but not really much of a neutrophilic response, and again, not much of the kind of cuffing that you would see with flu or something like that around the larger airways. I've seen 2 human patients, and they both had a much more interstitial disease. And to my knowledge, both of the patients I saw were not vented or treated. But one thing that is quite different from the 2 human patients versus our mouse model is the diffuseness of disease. Whereas similar to what Jerry was saying with the mice, I tend to see multifocal lesions, particularly most severe lesions underneath the pleural surface, versus the human patients, it seems to be pretty diffuse destruction throughout. We have started, there's a question on aging. We did young mice and old mice when it comes to SARS-2 with our mouse-adapted strain. That is ongoing. I've seen an N of 4 mice, 2 young and 2 old, on Monday of this week. And for us, so far, the young mice are showing more severe disease than the old mice. For what that's worth, it's pretty early. And I think that's kind of all my talking points without sharing. I can, like I said, if we stop recording, I could share some of the other stuff.
Your wish is my command.